Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Navdeep Tangri in Winnipeg, Manitoba, with whom we would like to discuss why, when, and how to predict progression of chronic kidney disease in nephrological patients. Thanks, Navdeep, for being our guest today and for taking the time.
Thank you. Thank you very much for having me.
So Dr. Tangri is an attending physician and associate professor in the section of nephrology, Department of Medicine, and the Department of Community Health Sciences at the University of Manitoba. And just for our colleagues in Germany, Austria, who are not just that aware where to locate Manitoba, it's right in the middle of Canada. And it's notable at least for two things. So right in the north, you find Churchill, which is called the polar bear capital of the world. And right in the south, you will find Winnipeg, which is kind of a capital for epidemiology and nephrology. Thanks to you, because you did all the work.
Thank you very much.
Thank you. It's right 10 years ago that you presented for the first time the kidney failure risk equation, which has gained tremendous success in the last decade and which has just been knighted by the UK, not by the Queen, but by the NICE guidelines, who integrate this equation into their NICE recommendations, which are known to be very robust recommendations, actually. So my co-moderators today are Anja Scheuer from Frankfurt, Germany, and Andreas Kronbichler from Innsbruck, Austria, and Cambridge, UK. My name is Gunnar Heine from Frankfurt, Germany.
Great.
I would like to start by giving an example of a 65-year-old male who has an estimated GFR of 27 and an albumin-creatinine ratio of 500 milligrams per gram. For him, the kidney failure risk equation calculates the risk, two-year risk for end-stage kidney disease of 9% and a 5-year risk of 30%. So what is the kidney failure risk equation and why should we use it in this patient?
Yeah, so thank you for that. So the kidney failure risk equation is a lab-based equation that predicts the progression of kidney disease, CKD stage 3 through 5, so when GFR is less than 60, all the way to dialysis or transplant. The important things or the key things about the kidney failure risk equation is that one, it's entirely lab-based and uses only 4 simple pieces of information: age, sex, eGFR, and albuminuria. And 2, it's highly accurate. It can predict progression to dialysis with a C statistic or an accuracy of about 90%. The third and important thing about the kidney failure risk equation is that it's externally validated. And I would say that none of you should use any model that's not externally validated. Externally validated means that it works in completely different populations from where it was developed. So it was originally developed in Canada, but it has been shown to be accurate in more than 30 countries in almost 1 million individuals. And that's why it was adopted by the NICE guidelines, and that's why it's used all over the world, is because people can have confidence that it works in whatever healthcare setting that they are working in.
So why should nephrologists use this equation, and why should primary care physicians use this equation?
So let's start with the easier case of the primary care physician, because I think that most kidney disease still lives in primary care. In Canada, as I suspect it's true in Germany and Austria and in the UK, 80 to 90% of patients with CKD are in primary care. So when patients have CKD stage 3 in primary care, particularly when they're older adults, there's a concern about who needs to be referred to a nephrologist and who doesn't. And in the UK and in several parts of Canada, they've decided that a 5-year risk of 5% should be a criteria for referral. And whenever in the UK and in Canada this criteria was used, the patients who got referred tended to be at higher risk, younger at the time of referral, with more albuminuria. So ultimately, it didn't result in more referrals. It just results in the right referrals, because nephrologists need to see higher risk patients, not lower eGFR patients. And a big message here is that GFR and risk are not the same. From a nephrology perspective, we use the equation to make a few important decisions. In my clinics and in clinics in Ontario, patients get team-based care, or what's called case management, when their 2-year risk approaches 10% or more. So that means that 10% or more over 2 years, they start to get a nurse, a dietitian, a social worker, a pharmacist, and a kidney doctor in their healthcare team, not just the kidney doctor. Once the risk is between 10 to 20, we introduce education about home dialysis, in-center dialysis, and transplant, and make sure that the patient has all their options to make the best decision that works best for them and their circumstances. And finally, when the risk reaches 40% at 2 years, that's when we put in a fistula. And 40%, for the audience, equals roughly 6 to 9 months for time to dialysis. So for the average person, that's about 6 to 9 months. And we think that that's what most patients need, right? Because most people need 1 attempt or 2 attempts to get the fistula right and get it working. And that can all take about 6 to 9 months.
How did you come up with the kidney failure risk equation? Can you tell us a little bit more about how it was validated?
Yeah, so initially we developed the equations in a cohort of patients referred to a nephrology center in Toronto, Ontario. We had about 3,400 patients who had CKD stage 3 through 5, whom we knew what happened because we had been following them for more than 10 years. So we looked at their lab criteria at the time of referral, and we said, could we predict using simple labs? So always our foundation in our program is building tools based on labs. So on lab criteria only, can we predict? And we found that this was highly accurate. And in 2011, we showed that this was accurate in another place, completely separate place of British Columbia, Canada, with 5,000 patients. So that led to a fair bit of uptake in North America, but really it didn't scratch the surface until our 2016 paper when we validated the equation with the CKD Prognosis Consortium in 30 countries and more than 700,000 individuals. Now this effort was really quite large and included about 15 or 16 cohorts from Europe and Asia, including cohorts represented from the Netherlands, from Germany as well. So I think all of this work clearly showed this, along with other studies done by independent investigators, that the equation was accurate no matter where we tested it. And if you ask me now, in hindsight, why did we find this? I think it's because of its simplicity. I think simple equations with not too many splines and cubic knots and things like that tend to validate really well in new data sets, whereas complex equations, which have a lot of splines and knots and a lot of different variables, tend to just overfit the data that's in front of them. And so they overlearn the intricacies of the data that they were trained on, and they often fail to generalize to wider populations. And that's the beauty in the kidney failure risk equation. It's 4 variables and simple relationships.
So will it work in any country, or did you make any modifications to it after you validated it?
Yeah, so there is a slight modification for North America and outside North America, and that has nothing to do with biology, and it has more to do with, the likelihood of a patient choosing dialysis with the same level of kidney function in North America versus outside North America. As you know, in North America, there tends to be a little more aggressive care at end of life and even for chronic disease in older adults. So the probability of receiving dialysis for the same level of kidney function is higher in North America. So there's a non-North American factor that we use to calibrate the equation to outside North America. And I would suggest we're using that in Germany and Austria, and I think that would work quite well.
Have you any more confirmatory studies planned, for example, in China or Japan?
Yeah, we're actually talking to a group in China at the moment. We're doing a study in China. But I think the major thing that I want to message, that I want to pass across, is that it's not really time to do more and more validation study in 50 countries or 60 countries. It's actually time to adopt and implement and do those studies. So I'm very supportive of implementation studies where we put the equation into a health system. Maybe we use it to determine nephrology referral. Maybe we use it to determine education, access, other interventions. And then we see if that improves the uptake of those interventions. I think it's time to test it in the real world and implementation rather than doing more academic papers. I mean, I'm an academic scientist. Professor Heine is an academic scientist. Professor Kronbacher is an academic scientists. So we all write papers. This is, what we do. But at some point, you have to stop writing papers and translate things into practice. And that's where this equation is now. I'm writing papers about other equations, but this equation, it's time for practice. It's not time for paper writing.
Talking about implementation, how is the kidney failure risk equation integrated into the NICE guidelines? You already hinted at it earlier.
Yeah, so NICE has been very proactive and recommended the equation as the first step to determine who needs to see a nephrologist. So they would recommend that every patient with CKD 3 through 5 have albuminuria measured, because you need that for the equation. And then you calculate the risk, and if the 5-year risk is greater than 5%, that patient should be referred. This will lead to integration of the equation in most major electronic medical records in the UK. And I think that's an important step in implementation in any country, and important for the audience who are listening today, is that the equation is very easy to program into your electronic health record or hospital system or lab system. And we've been able to do that without major technological challenges in Canada and the UK. So I think doctors who are interested, please feel free to take a look at the open source material, or contact us we're happy to send the codes and the equations to get it into the EMR, because that's what drives adoption. People want to see the result in front of them. Even going to an outside calculator is one more barrier that keeps people from using a good tool.
Is the kidney failure risk equation implemented in any other guidelines, or do you know if it's going to be?
Yeah, so it's in the European Renal Best Practice Guidelines for older adults. That was a few years ago. So that's been a positive recommendation. In Canada, it's part of reimbursement criteria for case management and team-based care. And health systems like Kaiser Permanente in California also use it to determine who needs to see a nephrologist. I think the biggest guidelines in our field are the KDIGO guidelines, but the KDIGO CKD guideline has not been updated since 2012. And an update is now finally due in 2022. So I'm optimistic that the guidelines will be included in this 2022 update, as they've been recommended by several KDIGO controversies meetings as the preferred way to triage patients with CKD.
Before Andreas goes into subfields of CKD, I would have just 1 or 2 brief questions on that. So in your original 2011 paper, you actually had 3 different equations. One was based on 4 variables, one was based on 8, I guess, and a third one was based on 7 or so. Is there still any place for the bigger equations? Because there you would need bicarbonate, which is sometimes difficult to get in clinical practice.
Yeah, so what we find is that the 8 variable equation, if applicable, is helpful in nephrology practices where bicarbonate, for example, gets ordered more often than PCP practices. I think for ease of use, we tend to really recommend the 4 variable equation because it's so easy to apply and easy to integrate. One thing that I can tell you about the 8 variable equation is we've learned that the cost of CKD, so if one cares from a health system perspective about the costs of CKD care, they go up the higher your risk. So even 2 patients with CKD stage 3, 2 patients with CKD stage 4, the high risk patient has much higher costs. And when we look at what's driving those costs, it's things like acidosis and hyperphosphatemia and anemia and the complications of CKD. So I think that when I think about in my own practice about a patient I see with CKD, I calculate their risk and then I look at their complications, because the complications are important for determining resource use.
And one other question in this regard. So you suggested that the equation might actually be implemented into lab software. But what's to do in hospitals when you have a couple of patients with acute kidney injury in whom the equation would overestimate the risk? So there should be kind of break pointing behind this to avoid such mistakes, which will surely kind of make patients anxious if they overestimate the risk.
Totally agree. So this is I think the same scenario that needs to breakpoint estimated GFR in acute kidney injury. As you know, eGFR from creatinine is only based on a steady state creatinine. And because we rely on the eGFR in our equation, it's based on a steady state outpatient eGFR. So in hospitals and settings of acute kidney injury, it's not reliable to use the equation. So I would say that there should be breakpoints in the EMR to do that. And I would follow the same logic from the eGFR to creatinine.
So based on your experience, you know that kidney disease is a quite broad term, honestly, and there are a lot of different diagnoses running into it. So GNs, diabetes, hypertension, and also genetic kidney disease. Does the equation differ for different underlying kidney diseases or for patients who received a kidney transplant?
Yeah, so that's a really fascinating question, and one I get often. So first, I think that kidney disease is much more heterogeneous when the GFR is normal. So above GFR of 60, it's polycystic kidney disease behaves very differently. GNs behave very differently. Diabetes, even diabetic nephropathy, or kidney disease with diabetes, are two different things at GF. What we find in our prediction experience is outside of people getting immunosuppression and having an active sort of rapidly progressive process, for 90% plus, kidney disease becomes more homogeneous when GFR declines below 60. And even in transplant, our equations tend to get more and more accurate when GFR is below 60. And in a study we did at below 45, they were just as accurate in transplants as they were in the non-transplant population. I think, I always think of like, I've always wanted proof of, I felt that kidney disease is more homogeneous, but then I was like, where's the proof? I think that the proof is in the DAPA CKD study. You see patients with diabetes, non-diabetic kidney disease. You see patients with burnt out GN, you see IgA, you see FSGS, and you see a drug that lowers pressure inside the glomerulus, protects the proximal tubule, and it's effective for across all causes of kidney disease. So, to me, I suspect, although this is a guess, I guess finerenone is going to show the same thing, because I think that once you have established kidney disease, the common injury pathway probably is hyperfiltration, high pressure inside the glomerulus, scarring of the glomerulus, kind of intraglomerular pressure, and tubular glomerular feedback and tubular damage. So I think probably this is why we predict well across causes, because it is pretty homogeneous at lower levels. Now that's controversial. I know some people disagree, but I think now I have DAPA CKD on my side, so I have more proof.
Yeah, DAPA CKD just excluded vasculitis and lupus nephritis.
That's it.
My two main diseases I'm treating, so prescribe SGLT2 inhibitors, but you're completely right. We need to test that in these diseases as well, and I completely agree here.
Yeah.
So moving on forward to another question, which is completely different now. So most studies testing the kidney failure risk equation in primary care focused on adults over 18 years, and but data implicated that this risk equation is also a powerful tool in children. Do you know if there are any initiatives in children ongoing also implementing this into databases, or let's say EPIC or EMRs?
Yeah, so I think that because Dr. Elaine Koo at UCSF has really led all of this work, and I think she's been very, very supportive. Now, I don't work in pediatrics, so I'm not as aware, but I think what we're going to try and do is have this implemented even for children as young as 12 or 13, so that if they have CKD, GFR less than 60, and the transplant data is very helpful in this regard too, because it's accurate in GFR less than 60 in transplant recipients also who are chronic, not acute, not in acute rejection, not in the first 3 months. But this tells you that similar to eGFR, if you roll it out, it'll be good for most patients. And I think that that's an important message here, because we cannot have a tool that is going to work for all patients. So the best we can do in medicine is find a good solution for almost everyone, right? eGFR is another example of that. It works for most people, right? But if you have extremes of weight, or if you have extremes of diet, we know creatinine is not accurate, right? And even if you use another equation, we know that they are better in some populations, not in others. But you have to find something, you have to find something. You can't just do nothing. So that's my view on this.
So when you integrated some years ago this North America versus non-North America factor, did I get it right that the North America factor is actually the original one back from the 2011 paper? So if you use your software where you get the same results as you got back in 2011, and you only modified the European Asian part of the equation?
That's correct. Yeah.
Okay.
So the North America is the original part. It's only when we tested outside of North America that we found they were systemically a lower risk outside of North America.
So there are some new challenges because we just learned that we should change the way we estimate GFR.
Yeah.
Leslie Inga has just
Yeah.
published her New England paper. And there are some changes actually both for Afro-Americans and for non-Afro-Americans. Do you have to modify the kidney failure risk equations, or are the changes just so minor that we should stick with the old equation?
Yeah. So one nice thing that happened was that just as this was all happening, there was a paper published in JASN recently by Glenn Chertow and Manjula Temura that showed that if you just remove the race coefficient from the current CKD epi equation, the kidney failure risk equation is just as accurate for Blacks and non-Blacks. So I think countries around the world are going to have a choice. Every country has different demographics. I work in Canada and live in Canada, where we have 1% of the population is Black, 99% is non-Black. Germany and Austria, I don't think are at 10%, which is where the US is. So I think every country is going to have a different choice. I think if you either will you choose the best CKD epi equation that works in your country, which could be just the old equation with the race removed, or you use the new equation to try and be uniform all over the world. And I think people need to work through that. I can tell you that if you use the old equation, but with race removed, it is just as good for Blacks and non-Blacks. You don't need to change anything. If you use the new equation, and if the world ends up going to the new equation, we will probably have to do easy to do simple study just to show that for most patients, their risk category, they may have little 1%, 0.5% change in risk, but we want to make sure that people's categories of risk don't change meaningfully. But I think the one important point this also illustrates, we always have to be adaptive. So probably in another 4 or 5 years, we're going to have to just make sure that once SGLT2 inhibitors are widely prescribed, that if CKD progression rates drop all over the world, then we may have to recalibrate the equations. And we're always happy to do work on equations. So this is not a problem.
For the time being, even as SGL2 inhibitors are rolled out, and I guess in Canada you already have finerenone, which is not yet available here in Europe, you would again recommend us to stick to the established equation and wait some years, and you will do all the works in the next years and then tell us in 2026 or something whether or not to modify the equation.
Yeah, I think that's fair. I think that it's amazing that these drugs have such powerful benefits, but yet because of many barriers in reimbursement and physician knowledge translation and all of that, rates still remain quite low. I think most recent data, for example, in the US showed that SGLT2 inhibitor rates were only 15% of eligible patients. And that was only in people with diabetes. So I think in non-diabetic kidney disease, this is not even happening, probably less than 5%. So I think at this point, I cannot imagine that the estimates have changed, globally. But perhaps in 5-7 years, I hope we make more progress and patients are on the best treatments possible. Then we'll be here to recalibrate if needed.
So hopefully Marcus at home is still running in 6 years or so,
so
that we come back to you and ask the question again. Then nephrologists are, at least again here in Germany, Austria, quite conservative guys. And for some reason or the others, many nephrologists still use the 24-hour urine samples for calculating proteinuria and albuminuria. In your equation, actually, you go for the more straightforward ratio from spot urine samples. Would the equation also be valid for people who do still these 24-hour urine collections?
Yeah, so that's a really good point. I wasn't aware of that practice, but in the original data that we developed in, and this never comes up because, often it's not asked, but we actually had a mixture also. We had a mixture of spots, and we had a mixture of 24-hour protein, and we had a 24-hour albumin, and we converted. So in the original papers, we converted everyone to a urine ACR or a ratio from either the 24-hour or a spot. So I think you can use the ratio, that's not a stretch in any way. You can use it and it would be just as accurate as and similar to what we did in the original paper. So that's an excellent point.
And then there are some people who say that all this albuminuria and GFR measurement is too strongly focused upon the glomerulus and does not take into account tubular function. And I just saw this week an HKD review that argues for a better uptake of measurements of tubular function. So could you imagine that one day or another, any of these hundreds or so of tubular markers could be integrated, or is your equation just so strong right now with its 0.9 C statistic that we just stick to it?
Yeah. So I think tubular markers are helpful, but they're perhaps helpful in predicting more upstream disease, for example. So if we wanted to predict, 30%, 40% decline in GFR, you need a little bit more. But my view, and this is maybe a controversial view, is I am not a biomarker guy. I think that the best tubular biomarkers are the things you already measure. Bicarbonate is a tubular biomarker. Phosphate is a tubular biomarker. Potassium is a tubular biomarker. So I think that I rely on commonly available data, and there are sufficient commonly available tubular biomarkers, and we will have some data coming out in 6 months showing you that an equation based on routinely collected lab data that predicts intermediate progression. So like, let's say if you have stage 1 or stage 2 disease, and you want to predict who's going to get to stage 3 or who's going to get who's going to progress quickly for clinical trials, you just need regular lab data still. You don't you're getting the non-biomarker perspective when you're talking to me. So yeah.
To which we strongly agree, because it makes it more difficult. That would be much more important, at least in our view, to integrate those strategies which are so well validated, like your equation. So we shouldn't go and discuss another novel and another novel, but just really go ahead with the present one, which are so strong. Now, there's one other very attractive estimation which has been published by Dr. Grams in Kidney International, I think 4 years ago, and you contributed to this work for people who are below 30, if I got it right, and that also integrate the cardiovascular risk. So is this a kind of addition to your equation, or how would you place this Dr. Grams equation?
Yeah, so I think it is complementary. I would certainly place it as complementary. I think all equations are very useful when you have a direct decision that you can tie to the result of the equation. So I like to give an example. Our equations are 90% accurate, and thankfully they actually influence your decisions, which is why people use them. But if you look at like CHADS2 is like 65, 67% accurate, but it's used all over the world because it ties an important clinical decision, right, to anticoagulate or not to anticoagulate. And so I think with Dr. Grams' cardiovascular equation, I think it's waiting for an important clinical decision to be tied to, because statins should be prescribed for everybody with a GFR greater than 50, with CKD older than 50. So I think if we start to get into, and unfortunately, a lot of cardiovascular trials exclude patients with GFR less than 30, which is terrible, right? Like trials of rivaroxaban, trials of PCSK9, trials of Entresto, all excluded patients with GFR less than 30. If nephrologists were prescribing these drugs, they may want to know which patients are highest cardiovascular risk, so that they could choose who to focus a more expensive drug on. And I think then it would become more and more helpful. So I think anytime you use any equation, mine or Dr. Graham's, whose work I respect a lot, and I think that's a tremendous complementary equation, is say, is this going to influence a decision for me? And only use tools that change decisions.
So I guess as you have been discussing a lot and have, of course, answered a lot of questions we have prepared here,
Yeah.
I would like to ask you one last question here. So you know that artificial intelligence, everybody's speaking about that, and it gains a bit more importance in nephrology, as has been shown in a couple of studies in AKI. Do you think that AI-based detection methods of progressive kidney function impairment will become available in near future?
Yeah, so really excellent question. So first, I think that there are some applications of AI in CKD already here, and we'll have a couple of review papers from our group coming out in the next few months discussing the challenges and potential of these AI-based tools. So AI is only useful when we have a lot of high dimensional data, so a lot of different variables, nonlinear interactions, and the last part is when you have a lot of missing data, because it's kind of the AI models tend to be a little bit better with missing data than regression. Now, unfortunately, the AI models that have been published to date, I'm thinking of a couple. I think there's one called Kidney Intellects by Renalytics, which has, TNFR, has like 100 biomarkers, so 3 biomarkers and about 100 variables. It's not externally validated, and the proprietary biomarkers, and even with all of that, even with internal validation, 100 markers, it only has a C statistic of 0.77. So I really don't see that kind of moving the field in any way. I think what you need again is getting back to principles, commonly acquired data, okay, data that's available for everyone, accuracy greater than 0.8, and kind of usefulness. Will it change your decision? And I think that's the key. So if someone comes up with one that uses routinely collected data and has an accuracy of greater than 0.8, then I think it's interesting. Until then, nothing is ready. And I don't think the tool that's developed, I don't think that's it.
I'm sorry, but I also have a last question on my part. So
Sure.
I know that there are a lot of randomized clinical trials going on that integrate your equation. And I think some of these are also done by your group. Would you just give us, as a very last question from our part, some idea in how far you test the implementation of your equation into clinical practice by these randomized trials?
Yeah, thank you. So far, what we've been really doing, and what we want to do more of, is to make this equation or other equations part of inclusion criteria into randomized trials. So for example, if you think about, a lot of trials are trying to do some of this, but they're doing it in an unnecessary complex way. So for example, recent trials I can point to, will allow a patient between GFR of 30 to 60 with low albuminuria, but if it's greater than 60, you can enter if you have high albuminuria. But really, if you look in the background, all they're trying to calculate is risk of outcome. So why not just use the risk from the equation and say, we will take anybody who has a risk of greater than X%. So that's what we're proposing. And in one of the trials which we're looking at in late stage CKD, we're taking people with a GFR less than 20, or if it's 20 to 30, but a kidney failure risk of greater than 20% over 2 years. So the first step, we're trying to combine risk with GFR, but ultimately, I think they should just go to risk, because if the outcome of the trial is CKD progression, why not select patients who are at highest risk of CKD progression? So I hope some of these results come out in the next few years and move trials towards risk-based enrollment.
So we're fascinated not only by the work you have done in the last decade or so, but also by all these ideas that you are presently working upon, and therefore maybe it's better to meet you once again before 2026 or so, because I think there will be some earlier, very important results coming on. So thanks a lot for taking the time for being with us. Have a nice afternoon. Manitoba, be aware of the polar bears, surely. And see you hopefully one day here in Germany and Austria. Thank you, Navdeep.
Thank you so much. Thank you for the wonderful opportunity. Bye-bye, everyone.